thank you all for joining us today. On behalf of the Radiologia Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Serfati, and I'm here with Dr. Hilary Humans. Now all Brazilians know Dr. Hilary Humans, MSK radiologist. And she coordinates and moderates this series with me. And I'm also here with our guest speakers, Drs. Jorge Vidal, Dr. Bruna Saroli, and Dr. Hilary Garner. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiologia Society of Rio de Janeiro. If you want to join the OCAD community, consider registering on the OCAD website. This session will focus on tumor and pseudotumoral lesions. The speakers will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. Just a quick reminder, attendees have not been given the permission to screen record any of these presentations as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speakers is illegal. We thank you all for your understanding, and with that, I'll kick off the session.
Hello, everybody. I have the pleasure of introducing my friend Jorge Vidal. He's a musculoskeletal radiologist from San Juan, Puerto Rico. He is a clinical associate professor of radiology at the University of Alabama at Birmingham and at the University of Puerto Rico Medical Sciences campus. He's actively involved in multiple radiological societies, including the Society of Skeletal Radiology, Colegio Interamericano de Radiologia, I can't say that, Jorge, Radiologia, and the American College of Radiology, amongst others. He's part of the RSNA Global Learning Center in Quito, Ecuador, and his areas of interests are trauma, musculoskeletal tumors, and musculoskeletal ultrasound. Share your screen, Jorge.
All right. Thank you for that introduction. There you go. And let me know if it's showing.
It is.
Okay, good. We'll move this over here. Let me just, okay. And you can all hear me well?
Yes, perfect.
All right, good. So this is a case of a palpable mass in a popliteal fossa of a 14-year-old female. Oops. And as we see here, we have T1 weighted images. We have a stir, and we see this mass in the popliteal fossa in the intermuscular location. And we notice that the lesion has fat that is iso-intense. I mean, not, it's slightly less intense than the subcutaneous fat. We see that most of it is lipomatous lesion. That we see that there are prominent flow voids. On pre and we see that in post enhancement, there's not a lot of enhancement of the mass, except for the flow voids and some thin delicate septa. And so the findings are a large intermuscular lipomatous mass, slightly hypointense subcutaneous fat, lots of flow voids, slight septal enhancement. On radiographs, if we had available, it would have been a radiolucent mass, and there's no osseous involvement. I'm also going to show a different case, a different patient, but similar findings. Here we have the radiograph of a large lipomatous mass. This was a case we saw last year. Again, no osseous involvement. We see, again, the lipomatous mass with large flow voids, thin septa, and the fat is not as intense in signal as the subcutaneous mass, the subcutaneous fat. Okay. We see that most of it sats out because it's a lipomatous tumor, and again, large central flow voids, very, very, very large flow voids. So our differential diagnosis for a large lipomatous mass in the extremity I like to divide them into two. They're either clean or they're going to be dirty. If they're clean, it's going to be a lipoma. If it's dirty, then we start thinking about liposarcomas, atypical lipomatous tumors, hibernomas. So lipomas, they got to be clean fat. And sometimes, or most times, it's actually cleaner than the actual subcutaneous fat because there's not a lot of septa in them. And it's going to be as intense as the subcutaneous fat. It's going to saturate completely on fat side imaging. It's going to have none or very few thin septa, and it won't enhance on post-contrast imaging. Now, the atypical lipomatous tumor, or how we used to know it before 2020, the well-differentiated liposarcoma, it's pretty much a dirty lipoma. So it's going to look, the fat is usually as intense as the subcutaneous fat, but it's way dirtier. It has more septa. Some of these septa might show enhancement, but it's pretty much a very dirty lipoma. The liposarcomas, the three major ones are going to be the myxoid, pleomorphic, and the dedifferentiated. Again, we have a lipomatous mass. But it's not as, the percentage of fat is going to be significantly less than we saw in the atypical lipomatous tumor. These are more soft tissue than fat, but they have fat within the lesion, which is part of the mass. And remember, no self-respecting tumor leaves fat behind. So the fat that's inside the tumor belongs to the tumor. And here we see how it has high myxoid content on STIR and then a lot of enhancement on post-contrast imaging. Whereas the pleomorphic is going to look again like a soft tissue mass, very thin septa. We see that they saturate on post-contrast imaging, on post-fat sat, and avid enhancement on post-contrast imaging. And I don't have a personal case of the dedifferentiated liposarcoma, but this is from Mark Murphy's radiographics article from a while back. And here's an example, which is basically two tumors in one. That's how I always remember it. You basically have a well-differentiated liposarcoma with a second tumor inside of it. And here we have a tumor with large calcifications, likely an osteogenic type sarcoma as the secondary tumor within it. And then we come to our example, which was a hibernoma, which is a rare benign soft tissue tumor of brown fat. The thigh is one of the most common locations, like the second case we saw. This was in the popliteal fossa, the first one we saw. It's a slow growing, painless soft tissue mass. It'll have a heterogeneous appearance. It's the key, one of the findings that is very common is that the fat is it's not as isointense as the subcutaneous fat. It's going to be slightly lower signal intensity on T1 weighted images, and they will have a lot of vascularity, which is a big clue. Also, if you have PET imaging, like this is a third case where we have this lipomatous mass in the vulva, and then we have this amazing uptick, very, very, very intense uptick, and it's because of all the brown cells causing all the brown fat cells, which are very metabolically active. Here's another image of the second case we saw with the large flow voids, and these large flow voids within the lesion offer some degree of specificity because they are not commonly seen in other lipomatous tumors like angiomyolipomas, liposarcomas, or other soft tissue sarcomas. Okay, so there is a lot of evidence that this is a big clue to the diagnosis. And these are my references, and thank you for your attention. Obrigado.
Thank you, Jorge. Now it's my pleasure to introduce Dr. Bruna Saroli. She's a board-certified musculoskeletal radiologist at Hospital das Clínicas from the Federal University of Paraná, South Brazil, and at Hospital Marcelino Champagnat. And she's also an adjunct professor at the University of Tuiuti in Paraná. She graduated with a degree in medicine from Pontifícia Universidade Católica, a medical residency in radiology and diagnostic imaging at Hospital Universitário Cajuru, X-Leme, a fellowship in MSK Radiology at DAPI Clinic in Curitiba. And she's currently working on her master's on MRI findings in inflammatory myopathies at Hospital at the Federal University of Paraná. She's a member of the bone pathology course team, as well as one of the coordinators of the oncology radiology meetings at the Federal University. Bruna, please share your screen.
Okay. Can you see my screen?
Yes. Perfect.
And can you hear me?
Yes.
Okay, great. Okay. I want to thank Dr. Aline and Dr. Hillary for the invitation. I'm glad to be here. Our patient here is a 33-year-old male with a history of traumatic fracture that happened 10 years ago in a motorcycle accident. It was stabilized with plate and screws, it consolidated, and the patient was discharged with no other concerns. In December 2021, the patient had a bicycle accident trauma. He noted a mild swelling on the right thigh. As he associated the trauma with the old fracture side, he did not seek medical attention, resuming his professional activities. In the following months, the pain increased. The patient developed erythema, and he had decided to go to an ER this past June. The team's initial suspicion was of an infectious process, possibly related to the fracture of the surgical plate. The patient underwent radiography at the ER, and you can observe the asymmetry in the thighs. In the first oblique incidence, we can observe callus formation inferring fracture consolidation. And in the second incidence, we can see the broken screws. We are not sure whether this is recent, as if it had occurred because of the bicycle accident, or whether it dated back to the first trauma. Here, we can also observe a solid periosteal reaction around the plate. In the distal oblique incidence, which is probably related to the previous fracture consolidation. There is a significant augmentation of the soft tissue around the implant, as you can see in the previous image, and here it goes all the way down to the knee joint. The CT axial slice sequence in here, non-contrast and post-contrast images show an expansive heterogeneous lesion whose epicenter is in the thigh posterior compartment. Observe some hyperdense areas inside the lesion, which means blood components. The post-contrast sequences shows heterogeneous enhancement. We can conclude that this is an aggressive neoplastic lesion opposed to the bruise or infection that was originally thought of. In the coronal T1 MRI images of the thigh, you can see this massive lesion that shows a predominant intermediate signal, with intermingled low signal foci and areas of hypersignal inferring a hemorrhagic component. In this coronal stir sequence, we can observe a heterogeneous signal lesion with intermingled hyperintense areas. And you can observe that the lesion involves almost the entire circumference of femoral shaft. Here, in the most distal portion of the lesion, we can see an area of hemorrhagic liquefactive necrosis, which is also characterized by the fluid level hyposignal on T2. You can see here, look here. We have to keep in mind that the magnetic susceptibility artifacts make the assessment more difficult. In pre-contrast T1 sequences, we observe hyposignal areas on T1 in the bone callus area, and some of these areas are also enhanced in post-contrast T1 sequences. which can be better observed after the subtraction here. Here is something important to note in this case. Actually, it is much more frequent that the primary lesion starts in the bone and infiltrates the soft tissue adjacent to it, than the other way around. This was the first thought that the orthopedists had about this, though we have to consider the massive volume of the soft tissue in contrast with the small levels of bone destruction observed. The region is most likely from soft tissue. Then a biopsy was performed. These are the hematoxin line and using staining histology slides, showing muscle cells at various magnifications. To reach a conclusive diagnosis, we also needed the immunohistochemistry, which is very helpful to determine the rhabdomyosarcoma diagnosis. And MyoD1 and myogenin antibodies are highly sensitive and specific for RMS, rhabdomyosarcoma, like this. This case is one of the rarest cases, the sclerosing subtype rhabdomyosarcoma. The patient was staged with abdominal and chest CT scans, and no metastases were observed. Although this lesion was not as responsive to chemotherapy and radiotherapy, and the definitive treatment choice being surgical excision, 2 cycles of neoadjuvant chemo was tried in an attempt to shrink the lesion, which you can see did not work. The lesion had greatly increased in size. Despite the necrosis, it grew considerably in the 2 following months, invading the other muscle compartments of the thigh. The patient then underwent surgical treatment with excision of the right lower limb. Here we can see the thigh with the increased volume, the scar from the previous fracture, and in the last image, the disarticulated lower limb. This is the radiography image at the immediate postoperative period. RMS is an extremely rare tumor and accounts for 1% of tumor in adult life. They are much more frequent in children, corresponding to about 50% of soft tissue tumor in this age group. There is a slight predominance in males, and most cases are sporadic, although there is an association with some family syndromes. RMS metastases are frequent and include lung, bone marrow, and lymph nodes. Adults have a poor survival rate, 5 years overall. It is worse prognosis when it starts in the extremities. These are some of the differentiated diagnoses: Ewing osteosarcoma, lymphoproliferative disorders, and others shown above. And here are the case reference. I highlighted this first article from 2022, whose quality was essential in the report of this case. Once again, I thank Dr. Aline Serfati and Dr. Rodrigo Aguiar for their support and encouragement. And thank you, of course, you all for being here.
Thank you, Bruna. Beautiful case.
It was a beautiful case. Okay, now we're going to wrap this up with Dr. Hilary Garner, who's an associate professor of radiology with subspecialization in musculoskeletal imaging at Mayo Clinic in Florida. She participated in a 7-year combined undergraduate and medical school program at the University of Florida and completed her internship, diagnostic radiology residency, and musculoskeletal imaging fellowship at the Mayo Clinic in Florida. She's published extensively and reviews for skeletal radiology, AJR, radiographics, and the European Journal of Radiology. She's the Associate Program Director of Musculoskeletal Imaging Fellowship, Associate Program Director of the Diagnostic Radiology Residency Program, and the Chair of the International Skeletal Society Scientific Session Committee. Okay, Hilary.
Okay, so you see my screen and you hear me okay?
Read through.
Yes.
Okay, wonderful. So my case is a 49-year-old man with right groin pain. He developed pain 4 months prior to presentation after lifting some fence panels. He has no prior history of pain in this area and no known medical conditions. Physical exam was negative except for mild tenderness to palpation over the right superior pubic ramus. Given the patient's history and physical examination findings, radiographs of the pelvis and right hip were obtained, which demonstrate a large, somewhat elongated lesion in the proximal femur, extending from the femoral neck into the subtrochanteric region. The lesion is predominantly lucent, but does contain some areas of sclerosis as well, but no clear matrix is really evident on these two views. So at this point, a mixed lucent sclerotic lesion. The lesion is geographic with a thin sclerotic margin and is mildly expansile. On the frog leg view, the more distal aspect of the lesion demonstrates a ground glass density or matrix, and there's no evidence of any associated aggressive features such as periosteoreaction, cortical involvement, or soft tissue mass. Radiographically, the appearance favored a benign diagnosis, and he had no personal history of malignancy. The more common lesions from the different World Health Organization classification groups of bone tumors are listed here. And based on his age, the location of the lesion, and the radiographic appearance, the primary radiographic differential considerations were fibrous dysplasia or another type of benign fibroosseous lesion, such as intraosseous lipoma with involutional change. Here's a different, slightly younger patient who has a similar but smaller looking lesion in her proximal left femur, which was a biopsy-proven fibrous dysplasia. And here another patient of similar age with a more sclerotic looking lesion in a similar location, which demonstrated large areas of internal fat, so consistent with an intraosseous lipoma. So we certainly considered both of those differential diagnoses as appropriate based on the radiographs. An MRI was performed to further characterize the lesion and to further evaluate his groin pain because his pain was not actually over this area of the location of the tumor. And on these sagittal proton density and fluid sensitive sequences, the tumor demonstrates heterogeneous signal with a more multilobulated area proximally indicated by the number 1, a more cystic or fluid containing area centrally indicated by the number 2, and a more homogeneous solid area distally indicated by the number 3. And then of course there was this more nodular area of PD hyperintensity that demonstrated signal loss on the fat saturated sequences. And the corresponding coronal T1 image also demonstrated hyperintensity. So this area is consistent with fat. On the post-contrast imaging, we see again the differing enhancement patterns within those 4 different regions, solid and peripheral lobulated enhancement proximally with a chondroid-like appearance, peripheral enhancement within the cystic portion centrally, and solid homogeneous enhancement distally, and of course, non-enhancement of the fatty area. One other thing identified on the MRI was a second bone lesion in the superior pubic ramus, which was not prospectively identified on the initial radiographs, but in retrospect, we can appreciate that there is mild expansion of the superior pubic ramus on the right when compared to the contralateral left side on radiographs. And there's also some subtle ground glass density of that medullary space. And just going kind of back to the MRI, we can see that the signal intensity of this lesion in the superior pubic ramus is most similar to the signal intensity of the more distal part of the femoral lesion. So given the multiplicity of lesions, the radiographic appearance with benign features, and the strange but overall benign MRI appearance, fibrous dysplasia was the favored diagnosis. And just for comparison, here's an MRI of a different patient with a larger fibrous dysplasia, replacing nearly the entire visible femur here, causing a bowing deformity. So certainly some kind of cyst-like changes, which we had a portion of our lesion did have that as well. So fibrous dysplasia is a benign medullary fibroosseous neoplasm with distorted, poorly organized, and inadequately mineralized bone and intervening fibrous tissue. On radiographs, it manifests as a non-aggressive geographical lesion with ground glass matrix, and it can have cystic change, like in our lesion. It can also have myxoid change, as well as aneurysmal bone cyst change. It can also contain cartilaginous components, although this is rare. It can also contain foam cells and giant cells, and it's not associated with periosteal reaction or soft tissue extension. It is associated with the mutation of the GNAS gene, which is detected in about 50 to 70% of cases. The treatment depends on presentation and symptoms, and for this patient, he was having groin pain and was mildly tender to palpation over the superior pubic ramus, symptoms which were attributed to the fibrous dysplasia in this location. He was prescribed bisphosphonates and was scheduled for follow-up radiographs and clinical evaluation 6 months later. At 6 months, there was no radiographic change in the appearance of the lesion, and his pain symptoms had completely resolved with 6 months of bisphosphonate. He was advised to discontinue the medication and follow up in 2 years with repeat radiographs or sooner if any new symptoms had developed. 2 years later, he was radiographically and clinically stable with no pain, and he was advised to follow up in another 3 years, which he did. And at this point, he was still pain-free, but the more distal aspect of the lesion did show increased expansion of the medullary space. So a small change in the radiographic appearance there. He was advised to follow up in another 2 years or sooner if he developed new symptoms. Well, 8 months after these 2021 radiographs were obtained, he fell off of a ladder and went to an outside facility, outside emergency department for evaluation. Radiographs were obtained at that time, which showed a non-displaced fracture line, or what they thought was a fracture line. And so he had subsequent MRI to kind of take a look at that, but also the lesion itself for further evaluation. And on the MRI, there is now extension of that proximal tissue component of the lesion into the posterior soft tissues. So an aggressive feature has developed at this level of the greater trochanter. And this component is the portion of the lesion that had that chondroid-looking appearance on the prior 2015 MRI. But now this more chondroid-looking component had replaced the other two more distal components completely, as shown on this sagittal stir image from earlier this year. So you can see that that cystic component centrally is now gone and replaced with the kind of the more chondroid-looking tissue, and then also that more distal tissue that kind of had more of a fibrous dysplasia look, and that little fatty nodule within it are also replaced by this chondroid-looking tissue. So this MRI was performed on the outside. He also underwent CT-guided biopsy at the outside facility in the area of the soft tissue extension, and that demonstrated grade 2 chondrosarcoma. He then presented back to our institution for further management once he had that diagnosis. And knowing that he already had 2 lesions, a bone scan was then performed prior to the biopsy to see if there were others. And there was kind of this question of, well, does he have Olier's disease instead of polyostotic fibrous dysplasia? It was kind of a confusing clinical picture. And so on his bone scan, we see that he had abnormal uptake in the known lesions in the superior pubic ramus and proximal femur, but he also had abnormal uptake in the right tibia as well as in the right first ray of the foot. And so he underwent radiographs of both of those areas for further evaluation. And we see kind of the classic look of fibrous dysplasia in both the tibial lesion as well as in the lesions of the first metatarsal and first proximal phalanx. To pathologically confirm that these other lesions were fibrous dysplasia, a CT-guided biopsy of the pubic lesion was performed, which did show fibrous dysplasia. MRI of the lower legs was also performed around the same time, which showed a myxoma in the right soleus muscle. So he was taken to the operating room for treatment of his biopsy-proven grade 2 chondrosarcoma, and so underwent wide resection of the proximal femur. And again, this did confirm grade 2 chondrosarcoma, and that was throughout the entirety of the lesion. They looked and looked for any evidence of fibrous dysplasia everywhere, found absolutely none. They did try to do the GNAS testing as well, but it just wasn't possible because there wasn't enough nuclear material to perform that particular molecular test, unfortunately. And so the final diagnosis in this patient was grade 2 chondrosarcoma in the setting of Mazerbrod's syndrome. We, of course, initially thought, okay, polyostotic fibrous dysplasia, but then that myxoma that we found in the right lower leg made this Mazerbrod's syndrome. And so there's one case report in the literature from 2015 describing chondrosarcoma of the femur in Mazur-Brod's syndrome. Mazur-Brod syndrome consists of polyostotic fibrous dysplasia and soft tissue myxomas. It's a very rare diagnosis with less than 90 published cases. Malignant transformation of fibrous dysplasia to osteosarcoma is extremely rare in this setting, with only 6 published cases. And to my knowledge, this is the only published case of fibrous dysplasia going to chondrosarcoma in the setting of Mazur-Brod's syndrome. Chondrosarcoma within fibrous dysplasia, monostotic and polyostotic, has been described in other case reports as well, but not in the setting of Mazur-Brod's, probably due to its rarity in and of itself. So here is his postoperative radiograph showing custom proximal femoral replacement with a bipolar hip arthroplasty. And that is the conclusion of my case, and I welcome any questions. And I want to greatly thank Aline and Hillary for inviting me to share this fascinating case with you, from which I learned a great deal.
Tremendous case, Hillary. Thank you.
Thank you.
Hillary, so I just shot you a question. Do you think that the chondrosarcoma has any relationship to the Mazur-Brod syndrome, or is this and the other one reported case just an exceptional and exceptionally unlucky person?
Yes, to my knowledge, and again, I'm no pathologist, that kind of knows the ins and outs of this type of molecular genetics of these tumors, as someone like Julie Fanberg-Smith would know. I think this is just an incredibly rare and unlucky occasion. And Mazur-Brod's is so rare to begin with.
So we would all just assume it's part of the fibrous dysplasia. I mean, there's no way to have.
Yeah, and so fibrous dysplasia is known to have cartilage components within it too.
Right.
That's in the WHO, book that it describes that. And so it's not unheard. I mean, that's rare to have cartilage within a fibrous dysplasia, but it's not unheard of. It's known. And so I think if you see cartilage components within it, it shouldn't necessarily raise your alarm bells in and of itself, but certainly something to monitor and follow. And if you see changes that are concerning, like, honestly, those radiographs that he had 8 months prior to his fall off the ladder, where we saw that new expansion of distally of that lesion, kind of in retrospect, I wish we would have done MRI at that point, since there was a radiographic change, even though he had no pain whatsoever. It was a radiographic change. So maybe we would have seen then that the cartilage component had really kind of taken over the whole thing. And that might, raise your alarm bells, but we don't really know if that in and of itself is super concerning or not with such a few number of cases.
So an unlucky patient that was lucky to fall off the ladder.
Yes, exactly. I know. It's interesting. I guess I should stop screen sharing here.
You can leave it.
Oh,
No
okay.
worries. Just leave it. So Jorge, I posted the question to everybody because this is always problematic for me. What's the recommended follow-up for atypical lipomatous masses? What are the accepted criteria for what constitutes thickened septae? How thick is too thick? And is there a size of the mass that matters?
So as far as I've always, with the surgeons I've worked with, most atypical lipomatous tumors or well-differentiated liposarcomas of the extremities, they're not in a hurry to take them out, because it's not like the well-differentiated liposarcoma in the belly. The extremity ones metastasis very rarely. So usually they take them out when it becomes a mechanical issue or a bulk issue, or the patient just doesn't want to have it inside their body. But it's not one that they rush to take out. As far as measuring the thickness of the septae, I don't measure the thickness of the septae.
I mean, specifically, you showed a case of a dirty lipoma. It was big. It was the dirty lipoma, and you said that they were thick septae and they were enhancing, but my understanding, I mean, to me, they look thick, thin and delicate, and they enhance because, you know, my understanding was those septae are fibrovascular septae and they enhance, so.
Exactly.
I will say that there is some new guidance from Europe. Actually, they published an article in October of 2021, experts from 6 different sarcoma centers throughout Europe. And they have basically 3 things that they consider when they're trying to determine, you know, how aggressive or non-aggressive something is and whether they need to go to a sarcoma center for further evaluation. And the primary thing is, you know, is it pure fat or not pure fat? Next is the location. Is it is it in the subcutaneous tissues over the deep investing fascia, or is it deep to that fascia? And then lastly, the size. And then they kind of break down in this cool little chart, which I think is pretty easy to follow, honestly. You know, if it's pure fat, but greater than 10 centimeters, and it's subcu, you know, fat location, even though it's pure fat and in a subcu location, because it's greater than 10 centimeters, yes, it could be a lipoma, but that's concerning enough. Anything less than 10 centimeters are like, no problem, leave it alone, you know, unless the patient wants it out. If it's not pure fat, they have other kind of like location and size criteria for that, and kind of determining whether it should go to a sarcoma center or not. And so it's really kind of those 3 different things that they really look at closely to make that determination of whether they need specialized, you know, sarcoma or evaluation.
I need this reference.
I can send it to you. I love it. I mean, I really do. I've actually used it several times in a few talks that I've given. So.
Thank you.
Me too, so I can share with everyone. There's another question. So thank you for the great cases, Dr. Jorge. In a dirty lipoma, how to differentiate degenerated lipoma from an ALT? Thank you. This is from H, someone called H.
So I guess it would be architecturally more than anything. If you have degeneration in a lipoma, usually it's going to be more central versus the well-differentiated liposarcoma. It's going to be just like the septi, again, the fibrovascular tissue throughout it. I'm not aware of any, and you know, I know Mark's on the line, but I don't know of any specific differentiation to a degenerated lipoma per se. And then I see another one with the main ultrasound feature of hybridoma. The only ultrasound I've ever seen of a hybridoma was one we did for a biopsy, and it was pretty much just heterogeneous hyperechoic mass with the phloboids were very evident.
Okay, thank you. Mark, do you want to share your thoughts with us? Hillary, you're muted.
I am muted? Am I muted?
Oh, no, that.
No, the other Hillary.
Oh, I see.
That's because I have no useful thoughts.
I actually, let's see. I'm going to share this screen. Do you guys see this?
Yes.
Yes.
Okay, so this is a slide from one of my prior talks on this topic, and this is my adaptation of the chart from that article. And the chart, or the article itself, is up here at the top of the slide, but I'm going to copy that and put it in the chat. But yeah, you can see, you know, is it superficial? Is it deep? And then these areas here, you know, if you ever see a fatty mass in any of these kind of anatomically complex areas, they automatically want you to refer it to sarcoma center. But you can see, you know, location, whether it's pure fat, not pure fat, and then kind of the size breakdown. So, but yeah, I'm going to just copy and paste this into the chat so you guys can see it.
So I will speak in Portuguese with our secretary to unmute Dr. Mark Murphy. Milene, você consegue desmutar o Mark Murphy, por favor?
Four series that were initially done.
Hi, guys.
Sorry.
Can you hear me?
Yes.
Oh, so I missed the one question Jorge had, so if somebody could repeat it. I'm working clinically, so I'm multitasking, which is very difficult for me.
Okay, in a dirty lipoma, how to differentiate degenerated lipoma from an ALT?
Yeah, typically both lipomas and well-differentiated liposarcomas can undergo fat necrosis, which creates globular areas that are not obviously fat. So I think in those cases, contrast can help tell you whether it's fat necrosis or you need to be worried about something else, like dedifferentiation. So I find that useful in those cases where I'm worried, well, could there be focal dedifferentiation? Is it just a well-differentiated liposarcoma with heterogeneous tissue, or is it just fat necrosis? And I find contrast quite helpful for that, for looking at that. I personally don't use size as a criteria for lipoma versus well-differentiated liposarcoma. It works if you have a group of 100 patients. It does not work in an individual patient. I've seen plenty of lipomas that are, over 10 centimeters in size.
Hi, my name is Dr. Jacobs. Radiology
Yeah,
resident.
and the article doesn't say that, if it's over 10 centimeters, it's definitely not a lipoma. That's not what they mean. They just mean that if it's over 10 centimeters, it probably would benefit from being referred to a more specialized center. So their article is more on management rather than differentiation necessarily.
And I think the other thing that's important to understand is the treatment of a lipoma and well-differentiated liposarcoma in the extremity is actually the same.
Oh,
Exactly.
It bridges from observation if the patient's older and not a good surgical candidate versus marginal resection, because well-differentiated liposarcoma in the extremity actually has 0 incidence of metastatic disease. It only becomes metastatically potential if it undergoes dedifferentiation, and we should see those changes. Very different than the retroperitoneum, which can engulf structures I used to know about and I've been told are important too.
That's right.
Okay, thank you very much. Thank you all, and thank you, Mark, for jumping in and answering our question. So the next session of the MSK case presentation series will be on November 18th. We focus on pediatrics. So
All right.
yeah, see you all then. Bye-bye.
Thank you so much.
For those who are going to the ISS, see you in Barcelona. Bye-bye.
Yes.
See you soon.
Everything. Have a good day.
Bye-bye.
One piece.